we're going to do a patient-doctor interaction. We were thinking about having professional actors do this, but we're not gonna. And so it's gonna be us. And these are the patients that you guys looked at this morning. And the two patients, I'm gonna start off as
Harry.
She's gonna be Sue, and I am gonna be the doctor of Sue. I'm gonna try to be the good doctor of Sue, not the bad doctor of Sue. And then we're gonna rotate, and I'll be Terry. Now, I guess since the only other actor from New Jersey has a nickname, The Situation, I want to have the nickname of The Conclusion. That's what we've figured out. Do you need an acting nickname? You need a stage name?
I think I probably want to not be remembered, so.
Fair enough. Well, this is being taped for posterity's sake, so this is it's going in the lexicon.
I really don't think.
So the goal here is just to see how you would have it. And this is not meant to, in any way, shape, or form, minimize the disease process that patients may have or to make fun of these types of things. The goal here is to do our best to show you how that conversation would go. And I would want to do it in such a way that it's done how you would have to have it in a primary care office. Because that's not an hour-long conversation. I get to have an hour-long conversation with patients, and so I can wait for their answer. I can ask an open-ended question many times and sit there. And so I want to talk with the patient, Sue, as though this is the first visit, the first time that I'm seeing her, and not the third or fourth time, and we can talk a little bit about that. So I'll break after the first time, which will only be about 2 minutes of a meaningful interaction, because after I've checked all the HEDIS measures, done all of my other checks, done the pneumovax question, the flu shot, and this and that. By that time, I have like 2 minutes for meaningful conversation. And then we'll flip to what the next visit should look like. So, hi, Sue. I'm Dr. Waller. It's really nice to meet you. Thanks for coming in for the first visit.
Hi. It's nice to meet you.
Yeah, no,
I'm having kind of a bad day.
Well, that's all right. I'm sorry to hear that. Is it something that we've done, or is it...
No, it's just my fibromyalgia is so bad. You know, I was diagnosed in 1991 by one of the top specialists at UCSF, and they said my fibromyalgia was like the worst they'd ever seen. And I just can't ever seem to get any relief. I seem to be really one of the worst and hardest cases, and nobody ever listens to me, and I'm just cycling out of control.
Well, first, I want to apologize. It sounds like you haven't, been able to really connect with anybody to have a conversation with this about. He maybe doesn't understand what you're having to go through, and so I think what I need to do is probably really understand what you think has been helpful and hurtful and all of those, so that we make sure that we don't cause any more trouble for you.
Well, I've tried everything. I've tried acupuncture, and I've tried physical therapy, and the only thing that helps me is medicine, and it's just exhausting. I'm exhausted all the time, and no matter what I do, I can't do anything. And my husband left me, and I don't have any friends, and all I need is just some breathing room so I can just take my medicine and just be able to function, be able to do the basic things.
Yeah, well, it sounds like that we definitely need to get some stuff done pretty quickly to get you feeling much better and being able to function. So what I'd like to make sure before we finish today is to make sure that we have a plan and that we actually try to get it done pretty fast, meaning that we do something today, but then I want to see you again in 2 or 3 days.
That'd be great.
So that we can follow up and see how that works. So because we never have as much time as we want to be able to get all of this, I'm going to give you a little bit of homework, but I also want to give you something today to help with this so that we can figure out what's going on. So in the past, what has helped you to feel like you could function?
Well, like Norco, like six, I can get by on 6. 8's a little bit better, but I can get by on 6, and I've been on that since 1991, and that's really the only thing. That's the only thing that's ever helped me.
And is it specifically the Norco with the hydrocodone?
Well, they've tried everything. I was on methadone for a while, and I was on a fentanyl patch for a while, and a bunch of other stuff, but mostly it's nothing works for me. The Norco, it helps me. it helps me
Yeah,
more.
and it seems like you were having some trouble finding somebody to give you consistent care because, we were kind of looking through the medical record and I saw that you had a number of docs, that you had seen, and it sounds like we need to find somebody to really play the leader of this and help out with that. And so if we're going to put you on a medication, which I think based on what you're telling me, that may have been the only thing that helped, and we'll talk about that in a sec, but we need to really consolidate down. So I would ask that if we're going to do that, that you make sure that we're the only docs and that you give me permission to chat with these other docs to let them know that we're going to take over care so we can get you everything that you need. Would that be okay with you?
Yeah, as long as, I just don't feel like anybody's listening to me. And everywhere I go, they just keep turning me away or they change their minds and I just feel like I can't get stable.
Yeah, and that's really frustrating for me to hear because that's the last thing that we want. So the homework assignment is going to be, I need you to write down or think about, and if you don't feel like writing it down, that's fine, but it would help me if you could write down all of the things that you used to be able to do that you can't do now, that you want to. And that would be helpful.
Everything.
But until then, it sounds like we need to get you on a medication, and it sounds like you've been on some very strong medications, and so why don't we, for the next 3 days, let's try medication. It sounds like you have pain all day, right?
I have pain 24 hours a day, every day, from the top of my head to the tips of my toes. Everything hurts. My teeth hurt. Everything hurts.
Yeah. So I think going to a strong medication that gives you that cover, for all day would be really helpful. Would you agree with that? Something pretty strong that would do that?
For sure.
So we have.
I've been on these medicines for a really long time.
Yeah, it sounds like it.
I have a very high tolerance.
Yeah. And I would actually calculate the dose based on what I saw, and then I would say, well, why don't we put you on one of the strongest medications that we have, Dilaudid. And we have one, though, that is long-acting. And this is nice because it's 1 pill a day, and it lasts for 24 hours. And I'm going to write that, and then you can take that 1 pill a day for the next 3 days, and then we can talk about that when you get here in 3 days.
It's not methadone.
No. It's not methadone. This is the same one that they would give in the emergency department if you broke your leg. So it's really strong.
Oh, okay.
But it lasts all day, and it's only 1 pill, and so you don't have to worry about this pill or that pill or what am I taking, and then it's easy, it's only 3 tabs. And then we can reevaluate this when you come in 3 days to see exactly what the pathway is going to be.
What about my Norco?
Well, that's something we'll talk about in the 3 days, but I need to know what you need to get done before we can start looking at all that. But I definitely want to get you on something that's going to help with the pain.
I want to thank you so much.
Yeah.
You're the first doctor who's listened.
Oh, no problem. And we'll do this every time, and we'll make sure that just call us if you have questions, and I'm going to connect you with one of the medical assistants in my office so that you have a point of contact to make sure that if you have questions or issues that we can get that taken care of. Would you like me to have them call you every day until we kind of have the next appointment?
Definitely.
Sure.
Definitely.
Great. We'll do that.
Okay, thank you.
All right. So a controversial thing right there, right? There's a risk inherent in having the conversation of knowing that if you say no to this patient for everything, that because you've told her that you've read the record, we've talked to her that you've seen the other doctors, we've come to the conclusion that we're going to consolidate care to a single place, and if I stopped her on her medication because she's on it, she would just go into withdrawal. And so what you have to do is you have to find what is one of your safest paths that you can do. And so the medications that can be helpful are some that are abuse deterrent, long-acting, that are not going to give you high peaks, and definitely are going to be less likely to interact with that. I just used the extended-release hydromorphone as an example, but it's a 1 pill a day, it's abuse deterrent, and it's generic, so you can get it. Sometimes it depends on states and prior authorizations and stuff, but in the end, you're going to have to compromise on visit 1. Most likely what will happen is the person you assign to them to call them, the medical assistant, will call them. I have my medical assistants call these new patients because they're going to call us, right? They're going to call you all hours of the day. So they call them twice a day. It's just a medical assistant phone call. Hey, Dr. Waller wanted me to call, see how you were doing. And then, is there something going on? And they're going to ramp up a little bit. It's not working because it's not working for what they needed it for. It's not. And so this is how that next conversation goes when either they run out early. Remember, we only wrote for 3 pills, so even if they took all 3 of those pills, it's safe. Right? Even if they took all 3 of them, it's going to be safe. I wrote enough of a dose to where you can give them a strong pain medication, but not enough to be an overdose risk. And there's really no diversion for that medication because it's crush resistant and those things. debatable, but there's only 3 tabs. So you either take it and not withdraw, or you don't take it, divert it, and go through withdrawal. And those are a lot of times that's the math that has to go through if they're diverting. I actually don't think Sue's diverting. I think Sue's using every one that she gets. And I think she's treating suffering and not pain. And so what we have to do is understand that, but you don't dive in at the first visit, because if you dive in the first visit, then you're going to lose them. And so the second visit would go a little bit like this. Sue, it's so great. I'm so happy to see you. You know, I talked to my MA, and she said that you guys have been having a conversation, and I think I have a good idea of what's going on. So do you want to tell me how you're doing first, or do you want me to just tell you where I think we are?
Well, I've been taking the medicine, and I'm feeling okay. I still have a lot of pain. But I'm doing okay. And I really appreciate that everybody's calling me. I feel like you guys really are caring for me.
Well, you know, the list that you made, and thank you for doing that, by the way. We're assuming she did, right? This usually takes 3 visits to actually get the list in for the homework. But it showed that there were a lot of things that you used to do that you just don't do anymore, and it sounds like some of those are maybe because you're maybe a little scared of doing them, and maybe tired, and you feel a little sad that you can't do that. And so I think that your pain has gotten so bad that it started to affect how you even see people around you and the things that are going on. So it's going to be just as important for us to work on kind of that sadness related to your pain as it is going to be the pain. And so the pain medication that we started you on is, I think, doing the job that it's supposed to do. And I know you're having more pain, but all of the science around your disease of fibromyalgia, which we have found that ultimately it has to do with a dysfunction in the spinal cord. And it's this little part in the back called the dorsal horn. And I'm going to draw you a picture on my whiteboard here. And that just looks like nothing. I know, it looks like a piece of meatloaf. But when you look in the back, this is messed up. And so we've identified what it is. We just don't have an x-ray like for a broken bone. So we know what the problem is. And we found that the best way to treat it is actually not with opioids. But since your function is increased, we'll keep you on the low dose for right now while we're working on these other things. And I think the more we work on physical activity and the more that we can have somebody interact with you, we're going to really get to all of these things on the list. How does that sound?
Well, for the first time, I feel like maybe there's hope.
Yeah,
but
I'm very hopeful.
My life is such a mess. It's really hard for me to see how things could get better, and I really would like my pain to be less. But I guess I'm willing to try anything.
Well, that's great, because I agree 100% with everything that you just said. I want your pain to be less. I want you to, I want us to be able to make you feel comfortable in what we're doing and be heard. So if you ever feel like you're not being listened to, you have to just let us know, okay?
Okay.
All right, great. And at this point, frequency of visit becomes important. This is a conversation that I've had with many patients, and quite honestly, by the second visit, by just having that empathetic tone, listening to what they're saying, repeating back to what it is, framing it not outside of their pain. I'm never telling them that their pain is not real. I'm never telling them that they're sad just because they're sad and that's making their pain worse. That's not something that I need to tell them. In fact, I've been barred from it from my therapist for doing any kind of therapy. So, but as we look at this, one of the things that you're going to have to do with this is understand in the short term, you have to do a little bit of a gut check and realize there's a transition period where you may have to write a medication that you don't feel terribly comfortable doing, so you find the best way for you to bridge the gap. Because over the next 2 to 3 visits, what you're going to be able to do, unless the function is significantly increasing, in which I have patients who this has been a great bridge to get them into physical therapy, to start physical activity, to show up, engage in cognitive behavioral therapies, and when that happens, they start to own wanting to get off the medication. And in fact, 3 to 6 months in, I've had many patients that look just like the patient, Sue, that come to me and say, I don't know if I need this.
Right.
Instead of me having to tell them that. Now, that's not all of them, but that's half of, at least in my experience, of a few hundred patients. So it's not a small number. And then when you look at the other side, we have to help them understand. We still don't tell them. You don't tell them. And now if they start to move into meeting criteria for an opioid use disorder, then that's a different ballgame. At that point, we now have a diagnostic criteria that we can point to and say, you meet for this, and this is definitely not the treatment for that. And so because of that, we want to switch it over to utilization of something different, and either that is to get you completely off of these medications and into therapy or onto buprenorphine, or if they become a severe opioid use disorder, looking at something like a methadone clinic. And a methadone clinic is 75% effective at 1 year as compared to 65% effective for buprenorphine, so it's more effective. It's not the med, I don't think. I think that ultimately what it is the consistency with which they're being seen, and so people with chaos in their lives now have to do something daily. And so that may also be a way to touch base for well-being if you coordinate with one in your local area. That's the harder part, I think. So that's the general concept of SUE, and now we're going to switch.
Now we're going to switch. And and so I'm going to try to do this in a similar way over 2 short visits. Again, this being a first meeting, and then a plan, and then a follow-up visit, because I think that works really well. So, good morning, I'm Dr. Rubinstein. I'm so happy you're here.
Yeah, thanks for meeting with me. I mean, my doc's quitting on me.
Well, I'm really glad you're here with me, and I hope that we can work together to take care of you. And I've read your medical record, but I really want to start by hearing your story.
Well, I was a roofer for years, and I had a couple of falls off the roof. I mean, that happens, and but I kept working, trying to pay the bills, and in order for me to go to work, I got put on some medication. It was the only way I could actually go to work and earn a living for my family, and it got to the point where I couldn't even get out of bed without it in the morning, and then if I missed a dose, my pain came roaring back, if I ran out early, because sometimes I had to work some extra shifts on the weekend, and I needed some medication because the breakthrough meds, just the Percocet that I was taking, just weren't really working. But every time that I went into my doc and it wasn't working, he would just up the dose, and it would seem to work for a while. But I haven't really been working for a while. I've now kind of gotten to where I'm not really able to do it because I fell one last time off the roof, and that time I really hurt myself, and I wasn't able to ever go back. And so I'm on disability now. All I do is suffer from this pain, and now, you're probably going to be like the last doctor I saw trying to transition out of my other one, who basically just said, you don't need to be on this stuff, and you don't even know.
Well, let me just say this, because I think we'll have a better relationship. I'm not going to make any changes today, okay? We're going to kind of just get to know each other a little bit. I'm going to get to know you. You're going to get to know me. You've been on this for a long, long time. I may have some new ideas. I may have some better ideas, but we have to whatever we're going to do it slowly as you get to trust me and I get to know you.
Yeah, so. Yeah. As long as you don't stop any of these meds, I just don't even know what I would do without these, and that's really the biggest scare that I have right now is that you guys are just going to kick me out of here and be done.
We're not going to do that. Okay, we're going to keep you, and we're going to work with you, and the goal is always to get you better. And so we're going to, whatever it takes. So I want to just say that right now. What I want to understand a little bit more is about how these medicines that you're on are affecting your life.
Well, without them, I don't even think I could get out of bed in the morning. And, without them, I can't really do my laundry. I can't really walk up the stairs on the basement. I'm not really able to walk out to the mailbox.
Okay.
And, so if I don't take them, I can't really do any of those things. And I can't really, without them, I can't really go bowling. Well, I guess I don't really do that anymore either. And then, I don't know, just without them, I just can't really do anything.
Understood. That's really common for people who've been on these medications for a long time. So I would completely expect that would be true, and I don't think that's abnormal. And it's sad. I'm sad that even on all of these medicines, and you have to take them every day, multiple times a day, they don't seem like they're doing for you what you need.
Well, I don't know. I just think that without them, really, I don't think that, Yeah, I mean, if you just increase the dose, though, I mean, I think that quite honestly, I'll be able to do all the stuff that I really want to do. You know, but we had this conversation with the last doc, and he's retiring, and he wouldn't answer my calls, and he just said, "Here's your letter, 90 days, good luck." And
I'm so sorry that happened to you. I'm really sorry. That's really hard. And getting to know a new doc is a stressful time, and I want to make this as easy a transition as possible.
yeah. I mean, he was kind of the only friend I really had. I saw him like a couple times a month or whatever.
I'm really sorry about that. Yeah. Well, let's see if we can really, I'm going to ask you a bunch of questions about various aspects of your life. Is that okay with you?
Sure.
Okay, because what I'm trying to understand is there a way we can make these medicines work better? Is there a better one we could replace some of these with? Should the dose go up? Should the dose go down? It's really hard to know unless we really understand all of the ways in which this is affecting you. So I want to ask you some questions, and some of these may seem really personal about your mood or maybe your personal relationships or something, but understand that this is how I'm going to understand how to best help you.
Yeah, I mean, I know my body. I mean, I know what I can and can't do. I mean, I know exactly kind of what I need, but if you got to ask questions, I mean, what I need is just a little higher dose of, you know, one or two more Percocets.
Well, when was the last time your doctor raised your dose?
It was 3 months ago after I came in early for, I ran out early, and I just told him I ran out early because it wasn't enough, and so he wrote me for an extra one a day of the Percocet, and I was on 3 a day and I went to 4.
How did that work?
No, I thought it was great. Yeah, I mean, it kind of changed a lot of stuff.
But how you doing today?
Well, I think it's time for another, increase in the dose.
And do you think we should just, I mean, let's play this forward a little bit. Where are we going to be in a year or 5 years from now?
Well, I mean, I want to be doing those things that we kind of talked about that I can't really do anymore, and it seems.
Has a dose increase ever helped with that?
Well, I mean, it does, temporarily. It seems to help out where I can go and do some things.
Do you think it would be good if we found something that was a little bit more permanent in terms of working for a little bit longer?
Yeah, I mean, a permanently high dose would be awesome.
Okay. Well, we want to look at this, and so at this point, I would probably lay out some options for him, and this type of a candidate that's on high doses of opiates, especially because there's benzodiazepines involved. We're going to be working together for a long time. It's going to take a long time to fix this, but buprenorphine may be a really good choice, and so I often will have not only a talk about buprenorphine and a handout on buprenorphine, but I find patients really respond well to printed out literature on this. Like, I'm going to give you a medical paper. I get that this may be, some of this may be harder or easier to read, but I want to show you the science that I find, for me at least, that works really, wow, you're trusting me, you're giving me the same stuff that you're reading, not just a handout that you wrote or that the government wrote or whatever. So I usually send people home with a whole lot of stuff, say, just think about it. And I'd probably keep you going on exactly what you're on, because I think that helps to build trust in the beginning. This is a marathon, not a sprint. And see you back in 3 days, a week, and ask you, did you read, what do you think of the drug that I was talking to you about at our first appointment? Does any of this look like it's something that you might want to consider?
I don't know, there was something that said that it actually, it basically sounded like it was stronger in some ways than the other med, but they mentioned for addiction, and I don't have addiction. I mean, I don't know which.
Right.
I'm not one of those people. I mean,
I understand.
I'm not trolling around trying to. I don't do that.
And I know that. And I just want to say, I am a pain physician, and I don't treat my patients primarily for addiction. It's just that it's the same drug that we can use it for both. And when I'm using it, I'm really using it to treat pain. And if it doesn't work and your pain's not better and you're not able to do more, we'll put you back on something else. So you don't really have there's nothing to lose. In other words, I'm not going to make it so that you are stuck anywhere.
Well, can we, I mean, I really want to, I mean, I read, I didn't understand a lot of it, but the picture was pretty interesting when it talked about how, you know, people didn't go to the hospital as much on a little chart thing, and we didn't have to, constipation, which is really a huge issue for me is,
Right,
you know,
we talked about that last time.
yeah, and I mean, can we maybe go just a little longer and let me think about it a little
Okay,
bit?
so let's make a deal between you and me. How long do you think you want to think about it?
I need at least like a week or two to just go, because I have some family members with pain, and I maybe want to talk to them a little bit.
For sure. I'm happy to wait a week or two. In the meantime, what I'd kind of like you to do is really monitor yourself and look at your life and see, you know, you're a young man, you're a very young man, and there's a lot of things I'm sure you want to do, and it doesn't look like right now we're in a good space for that. We're not getting a lot of bang for our buck. So my whole goal here with you is to try to get your life better. And
Yeah,
you know, I want you to be comfortable with this. I'm not going to force you to do anything, but I'd like you to really, you know, we can take another week, then I'd like to see you back again, and then I'd like to see if we can talk about transitioning you to something that I think is both going to help your pain a little bit more, and as a bonus, that one of the things I really like about this drug is it seems, unlike the other ones, it doesn't sort of poop out. You know how?
Well, I need some poop out. I mean, that's
Well,
like,
I mean, it doesn't. When you go up on a dose in a few weeks, you're right back where you started from. So I'd kind of like to find something that would keep working for you, and that's why I'm particularly interested in considering maybe getting you on this and seeing if we can get something to last a little longer for you.
all right. I mean, I just want to hang out with my friends again. I haven't seen them in a long time. So,
And
all
that's
right.
a really important part.
That's fine, but just don't. I mean, just don't like fire me or.
I'm not going to fire you.
Me out there, okay?
I have one rule. I will work as hard for you as you work for yourself.
Well, I'm a hard worker. I mean, I always
Yeah,
have been. So we'll
I
get
will match you inch for inch.
there. Okay.
Okay?
All right. Fair enough.
Awesome, guys. Thank you so much. I just wanted to reflect a few things. I mean, there's no way that in 5 or 10 minutes we can really reflect the hard work it takes to take two people whose entire life is revolving around their medication and get them to see a life outside of that. And what I want to credit you all is in this short period of time, you brought out the need to increase activity, to focus on function, both of you showing unconditional positive regard and lack of judgment, which I think is key with people who feel shame in every day of their life. And also just that this is about relationship and doing small changes over time. Because as soon as you said the word delighted, I saw a bunch of people in the room said, well, we can't fix this with meds. And I think the point is you have to do these changes slowly, and I really appreciate you modeling that. So thank you. I had several questions come in. One that I thought we should address before we break for lunch is help us understand why is it that the brain gets changed so much, whether you're taking it for addiction or you're taking it for pain, what's actually happening in the brain, and why is it that some people get addicted and some people are able to get off the stuff?
So I think the core of this, and we have a pretty solid research cadre around this nowadays, and this area of the brain called the reward system, which has multiple pieces to it, including the emotional centers, emotional memory centers that live in this little place called the amygdala, and then you have the nucleus accumbens, which is like the happy center, and the ventral tegmental area, which is the freight train to happy center, and ultimately, those areas are meant to live within a certain amount of happy. And the minute that they get outside of that happy too often, the body tries to get it back down and squish it down. And so it decreases the release of dopamine, which is that main chemical there. And over time, if the body is forced to produce too much dopamine, it will decrease that. Now there's genetic variability, which allows for somebody to have a higher risk of a big release of dopamine as compared to a small. And so we start off with that genetic risk. And what we're also finding is there's this thing called epigenetic risk. That means things that are done to your DNA from nature. And we're finding that nature and nurture are the same. They're no longer separate because there's some mice studies that live in They live at NYU, I guess. But they've done these studies, and what they did is they had a genetically created mouse that was built to not like drugs, all right? Teetotaler mouse. Force-fed it drugs. Bred it with another genetic mouse who was not another teetotaler, right? Their offspring liked drugs. The offspring of that one liked drugs. The offspring of that one liked drugs. 5 generations of 2 genetic teetotalers, just because they force-fed drugs, created a change in the DNA that seems to be able to be passed down generationally. So this is why we're seeing the children of people who have an addictive disorder have a significantly higher risk of addiction later in their life. And you add on things like trauma, which go hand in hand with the disease. You add in things like homelessness, and you add in, just availability of drugs and all that suffering that can get abated quickly with that. That significantly increases the risk for addiction. And all of those things together can't just be quieted with one medication. So it's not like you can give somebody buprenorphine or methadone or naltrexone and then immediately that switch is flipped. You can, however, quiet the voices enough to allow dopamine to start to build back up naturally because of the way that these meds work, and they're not taking them in high doses, which is suppressing it. And because of that, then you can add in the behavioral therapies like cognitive behavioral therapy, motivational enhancement therapy, the cadre under CBT that lives there. And with that, you can actually start to rebuild all that coping, undo some of that trauma to the point where they create enough of a buffer system so that they don't have to cope with a chemical. They can cope with their own, neurons. And so some people just don't do that well, and we're finding that it's actually more complicated than we thought as far as the genetics of this and how it flows. And there's probably a subset of patients that permanently harm that reward center. The animal models that look at this look at the equivalent of 60 human life years, and they found that they don't regrow. That if they've gone through what we call apoptosis, which is this programmed cell death, that we actually have lost or had a stroke in the happy center of the brain. And these patients may need medication to augment dopamine, which is buprenorphine and methadone, for long periods of time / permanently, because they just don't literally have the neurons to do it. So figuring out who those patients are compared to the ones we can wean off after 2 to 3 years when the brain stabilizes, that's where the lion's share of work's going to be coming in the future, because we're going to have a big uptick, hopefully, in people on medication to stabilize the disease. And then in 2 or 3 years, we're going to need to be answering the question of who do we get off?
Who do we get off and who do we
And that's going to be a hard one to answer, I think.
Well, thank you again. Show of hands for their excellent acting skills.